So my dear colleagues, it is my first time at the shoulder course of Athens, so thank you very much for the organization, and thank you very much especially for Manos for this very kind invitation. So let's go to what is a pseudoparalytic shoulder, and I think this is probably one of the challenges for the next year. So I have no conflict of interest for this communication, but it's a very good question, I think, because I will try to agree together. We're going to try to agree together just to start with this communication. And I will try to show you 3 points. I think a massive cuff tear is really different from an irreparable cuff tear, and it is really different from a pseudoparalytic shoulder. So, you know the definition of a massive cuff tear. Look at this massive cuff tear. This is a definition more than 5 centimeters and more by 2 tendons. But you can see progressively this cuff can be mobilized with a deep layer here, and if you are able to repair this deep layer with the superficial layer at the end, you have repaired the cuff. So you can see that a massive cuff tear is not synonym of irreparable. On the same idea, what is an irreparable cuff tear? So what about the retraction, the reduction, the muscle belly atrophy, superior escape, fat infiltration? Probably. So before your surgery, you can know whether you will be successful or not with your repair. For example, if you see a muscle atrophy, be careful, because probably your repair will not be very nice. With the same idea, as soon as you have a superior escape of your shoulder, less than 6 millimeters, you are sure that you have a massive cuff tear with 2 or 3 tendons, and be careful of your repair. This is a bad point. You have also the Armada classification after the stage 3 with acetabilization of the acromion. It's not very good, and be careful, you have a high risk of trying to repair this cuff. And of course, I think this is the point, or one of the points. As soon as you have a fat infiltration more than 3 or 4, probably it's the dream to think that you are able to repair. Please do not try to repair. This is a very recent French study, and you can see the risk factors: smoke, cholesterol, hypertension, diabetes, and so on. And when the patient has more than 5 risk factors combined, so the rate of healing is 0%. So be careful of your patient. And I think you are not better than your colleague. If your patient had this double repair with a massive cuff tear, don't try to repair it again, because I think you are not better. You have to find something else, I think. So what is a pseudoparalytic shoulder? This is the definition today. It's a normal range of motion with an active elevation left for 45 degrees. I would add, but it's a personal point of view, no external rotation active or internal active too. So this is a massive cuff tear, but it's not a pseudoparalytic shoulder. You see, this patient is very strong with big deltoid probably, and he has a massive cuff tear, but it is not pseudoparalytic. So these are 3 different points. So now, what difference between this patient with his X-ray, who has a functional shoulder, with this patient who has exactly the same X-ray, but with a pseudoparalytic shoulder? This is the question today. So my question is why a functional shoulder can turn to a non-functional shoulder. What happened in the shoulder? I think we have to go back to the biomechanical, and I was very happy this morning to listen to the communication of Dr. Adar. It was just a beautiful communication and a very nice introduction to this part. There is the horizontal plan and the vertical plan, and this was described by Burkhardt many years ago. So in the vertical imbalance of a shoulder, the deltoid is stronger than the supraspinatus, and because of that, you have a superior escape of the humerus. Everybody knows that. You have a loss of active elevation, but you have a preserved active external rotation. This was described by Pascal Boileau. He called this the highly isolated loss of elevation. This is vertical imbalance of the shoulder. On the opposite, you have the horizontal imbalance of the shoulder. Everybody knows that now. This is the insufficient loss of external active rotation. In fact, the external rotation are weak because absent, and very strong internal rotation with the subscap, lat dorsi, teres major, and pec major. In that situation, the patient is able to lift up his arm to have a nice elevation, but is not able to have external rotation, and he has a hornball sign. He is not able to drink a glass of water. Look at this patient. It's typically, there is a deficient of teres major. This is what Pascal Boileau called the isolated loss of external rotation. So when you have both horizontal and vertical imbalance of the shoulder, you have no active elevation, you have no active external rotation. Pascal described the combined loss of elevation and external rotation. And this is, for me, the definition of a pseudoparalytic shoulder. So in that situation, what happened? You have a lesion of the suprainfraspinatus, and you have a posterior and superior escape of the shoulder. And Philippe Collin showed that in that situation, one shoulder out of three turns to pseudo-paralysis. So this is the conclusion to sum up the Pascal Boileau, and this is the slide of Pascal Boileau. It's not mine. You can see the highly, the insufficient loss of elevation on your left, the higher insufficient loss of external rotation of your right, and the combined. But what happened about the subscap deficiency? I think Pascal probably forgot the deficit of internal rotation active. You know, like me, that the subscap lesion is more frequent than you can imagine, and I've described the highly, I don't know if my pronunciation is good enough, insufficient loss of internal rotation. Imagine you have no subscap, and the subscap in itself is more than 50% of the strength of the shoulder. So no subscaps means no internal rotation, even if you have pec major, lat dorsi, and teres major. Because of that, the external rotation is stronger, and you have a problem. And look at the publication of Philippe Collin. If you have no subscap and no supraspinatus, you have an anterior superior escape of the shoulder, and this creates 80% of pseudoparalytic shoulder. And this is, I think, one of the points of the comment today. So to sum up, this is the communication of Pascal Boileau. This is mine. I think when you have a combination of the anterior, superior, and posterior lesion, you have the central part of this part, you have a real pseudoparalytic shoulder. But pseudoparalytic shoulder means a minimum of 2, maybe 3 tendon rupture. And this is the conclusion. So now, how to restore the vertical imbalance, for example? You see this patient on your left has an active shoulder, but very painful shoulder, and it's difficult for her. This is what she has an active external rotation. I think this is the highly type 1, because Pascal Boileau just described the highly, but I think there are different steps in the infusion of elevation. Highly type 1. On the opposite, the second patient has, for me, a highly type 2. He has not a pseudoparalytic shoulder because he has an active external rotation, but he has no active elevation. It's a highly type 2. So, first of all, when you have a highly type 1, this patient, she's very painful, she has a painful shoulder, difficult for her to have a forward flexion or an elevation. I think you can use the lat dorsi, and you can put the lat dorsi over the top, and I published recently my data about the result of the lat dorsi in this indication. But beware, and this is in my publication, if you have a total deficit of a forward flexion of elevation before the surgery, if you have an highly type 2, in that situation, I think the lat dorsi is not strong enough, and then probably the reverse shoulder arthroplasty is a better option. So now what about the horizontal imbalance of the shoulder? First of all, I propose to discuss with you the deficit of external rotation. So probably you know L'Episcopo, who was American in 1934. It was not very recent. He published the transfer of L'Episcopo, very well known in the pediatric obstetrical palsy. And this was to restore external rotation. And just Pascal described a more recent technique, but exactly, in fact, the idea of L'Episcopo, just to turn around the humerus with a double transfer, lat dorsi and teres major, to restore active external rotation. So this is, of course, a first option. But the second option, and I published also this result, is the lat dorsi, but you don't fix the lat dorsi over the top. You fix it more posteriorly into the infraspinatus, onto the infraspinatus, to restore external rotation. But it's not a dream, as you can see, because in our data, the restoration of external rotation was only between 12 to 15 degrees. It's not a lot, and we were a little disappointed with this indication and these results. So probably the lower trapezius transfer is better for this restoration of external rotation, because the lower trapezius transfer biomechanically is stronger than the lat dorsi to recreate external rotation arm of the body. Why? Because the direction of the lower trapezius is exactly the same than the infraspinatus, and this was used by Bassem El Assad from the Mayo Clinic. One of the problems with the lower trapezius transfer is too short to reach the humeral head, and you have to use an allograft, and this is, for me, probably a problem, especially in my country. So what about now the internal rotation? How to recreate the internal rotation? Of course, if you have no subscap, so how to recreate a subscap? And the first man who imagined this is Michael Ruth with the pec major transfer. And you can use either the sternocostal portion, either the clavicular portion, and you can transfer to the top of the humeral head, and you can recreate the subscap. But one of the problems is the subscap comes from the anterior chest wall. And it's not logical, because the subscap comes from the posterior chest wall. If you want your subscap to recreate the action of the subscap, you have to go behind the conjoint tendon to have a good active and excursion of your tendon. The problem is with this 90 degrees turn, I'm not sure that the excursion of your tendon is very good, and no publications have shown the superiority of this technique. So because of that, you see, it's not logical. We imagine just the lat dorsi to recreate the subscap. Why the lat dorsi? Because the lat dorsi comes from the posterior chest wall, and probably is more biomechanically is more efficient than the pec major. And this is the publication. We show arthroscopically a technique, and with the first result of the reconstruction of the subscap with the lat dorsi, which is an internal rotator, exactly like the subscap. So what happens when you want to restore both horizontal and vertical plane? This is a problem, and this is the slide of Pascal Boileau. Probably you know this slide. You can put, of course, you can implant a reverse shoulder prosthesis, but you will have no rotation. And this is the price to pay. The patient has no pain, is able to have a good elevation, but has no rotation, is not very happy. So you can you can try a tendon transfer, but what's the problem of a tendon transfer? Why the lat dorsi does not work well in that situation? Because remember, please, the rules of a tendon transfer. One tendon means one transfer, means one function. But and when you transfer your tendon, you lose the power of your tendon, of your muscle. And in a pseudo-paralytic shoulder, you have a minimum of 2, maybe 3 ruptured tendons. So one transfer alone is not strong enough to recreate the function. Maybe you can use a double transfer, but the technique is demanding, and the results are not so good. So for the first option in that situation, you can use a reverse shoulder arthroplasty plus an episcopo technique plus a transfer. This is the idea of Pascal. This is option 1. But remember something maybe easier. When you lateralize the center of rotation of your shoulder, you recreate, you retension the remnant cuff and the anterior part of the deltoid and the posterior part of the deltoid. And because of that, you can recreate part of rotation. Because of that, you can use, and this is the topic of this afternoon, you can use a bio RSA. You lateralize the center of rotation of your reverse prosthesis, and with that option, it's possible to have better rotation than before. And something easier, you can use lateralized implants, so you don't have to need any graft, and you can have the same result. Okay, in conclusion, either you have only one tendon, one direction. I think one tendon, it should be better to write less than 2 tendons. it's a posterior superior deficiency with supra-infra. I think you can make either a lat dorsi or a lower trapezius transfer. On the opposite, if you have an anterior superior deficiency, I think the lat dorsi today probably is the best transfer for the subscap. If you have more than 2 tendons, probably 3 tendons, 2 directions, and a real pseudoparalytic shoulder, in that situation, we are in the world of the prosthesis. Vertical imbalance of the shoulder, your patient will be very happy with a reverse one. On the opposite, you have horizontal and vertical imbalance. In that situation, a reverse alone is not efficient. You have to make a transfer in addition, or you can try a bio-RSA or lateralized implant. Thank you very much.